Hello, everyone. Thank you for joining today's session on your favorite channel, Cancer Reach. Cancer Reach is an initiative by our very own doctor, Dr. Krishnamani, to spread awareness about cancer and to help patients and caregivers access the right treatment at the right time. As we observe Sarcoma Awareness Month this October, it is an important reminder of the need to shed light on these rare and often non discussed cancers. Sarcomas may account for a small percentage of all malignancies, but their impact on patients and families is profound, making awareness, early diagnosis, and research all the more critical. Joining us for today's session on the Silent Invader, Understanding Rare Sarcomas and Its Impact, is Dr. Krishnamani, one of the most respected voices in the field of oncology. For over a decade, he has been a cornerstone at the AOI hospitals here in Hyderabad, where he specializes in the management of solid hematological tumors and oncological emergencies. His journey includes prestigious international fellowships and leadership roles across some of India's leading cancer centers, reflecting both his depth of expertise and his global outlook on the cancer care. Beyond clinical practice, he has played a vital role in shaping cancer care policies, refining treatment protocols, and contributing to impactful research. Hello and welcome to you, sir. Sir, am I audible?
Am I audible?
Yes, sir. Yes, sir, you are audible.
So, hello and welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness about cancer. And as you said, today let's talk a little bit about sarcomas, continuing on our earlier week's topic, which was specifically on bone sarcomas or bone tumors, rather.
Sir, can you explain what is a sarcoma tumor?
See, sarcoma by definition is a tumor or a cancer which arises in the connective tissue, that is the muscle or the bone. It can also include rare varieties, which could include cancers which arise in the blood vessels, which we call hemangioendotheliomas or in fibrous tissue. So basically, epithelial malignancies are called carcinomas, lymph node malignancies are called lymphomas, and sarcomas are the tumors which arise in the soft tissue, the connective tissue, which includes the muscle, bone, fibrous tissue, the blood vessels, etc.
Sir, why are sarcomas termed as silent invaders?
See, first we should understand that sarcomas are extremely rare tumors when you compare that to normal cancers like your breast, cervical, lung, or head and neck cancers. So the incidence of sarcomas is less. And in that also, there are some common sarcomas and some very rare sarcomas. The common ones are, again, if you look at the bony sarcomas, you will see osteo and Ewing sarcoma, which are extremely common. There are very rare varieties like, as I told you, hemangioendothelioma or angiosarcoma. Angiosarcoma is a sarcoma coming in the blood vessels, or a hemangiopericytoma, clear cell sarcoma, uh, soft part sarcoma, etc. These are extremely rare tumors. So, uh, so the problem is the identification is an issue. The rarity is one major issue, because of which people present late. By the time they come to a doctor sometimes with certain types of sarcomas, the disease usually spreads to the lungs. Lung is the commonest, thorax is the commonest presentation for distant metastasis. So with some sarcomas, the first presentation itself could be a lung metastasis, which is an advanced cancer. And also the problem with sarcomas is the location. Sarcomas can come either in the extremities, that is your legs or hands. It can also come in the abdomen, which is called the retroperitoneum. So the retroperitoneum is such an area where you have a large sarcoma, it is difficult to operate. And after that, if radiation has to be given, it's a very large area where radiation has to be given and there'll be significant amount of toxicity. So the disease due to its rarity is seen late, disease due to its non-specific symptoms is seen late. The disease has a propensity to spread to the lung metastasis. It comes in certain areas like in the legs where amputation is required, where the abdomen, where any treatment after surgery or including surgery also has significant morbidity. So these are the issues. That's why it is called a silent killer.
Sir, can you explain which gender is more commonly affected with this disease and which age it usually occurs in?
Generally, men more than women. Age group, you can see sarcomas in the young age, middle, and adult age. In the children and adolescents, we see osteoevings. We discussed that. In the middle and adult age, we see a lot of synovial sarcomas, liposarcomas, those kind of things. Adult age sarcomas are usually seen due to prior radiation and those factors, or if they have certain familial traits. So no age is exempt, but generally osteoevings are seen in a younger age. Mid and adult age, you see synovio, lipo, and leiomyosarcomas.
Sir, any typical causative factors for these cancers?
Some of the common causes are, as we discussed last time, prior radiation, presence of retinoblastoma in children. Uh, so these are some of the factors which are generally implicated, some rare mutations, but nothing as such which is extremely specific for development of a sarcoma.
Sir, what are the signs and symptoms for these cancers?
Depends on the location. If you have an extremity sarcoma, somebody may present with a lump or a swelling in the leg. They may present with a swelling in the leg or in the arms. They may have a painless swelling. Sometimes they may have a limp, especially if it is in the leg. If it is spread to the lungs, they have breathing difficulty. They may have dry cough. Uh, if there's an abdominal sarcoma, they may have early satiety. That is, if they eat little, they feel full, they feel bloated. They may have a nauseous sensation. They may have loss of appetite, loss of weight, some bowel changes, and these kind of symptoms.
Sir, can you walk us through the diagnosis for these diseases?
The sarcoma, the essential diagnosis of a sarcoma in a particular area is usually by an MRI. If you have it in the leg, for example, you are going to do an MRI of the leg or MRI of the hand. You are going to know the size of the sarcoma, the character of the sarcoma, the neighboring structures, how it is related to the vein, nerve, etc., artery, etc. If it is an abdominal sarcoma, CT scan is a good test. Again, if it's a head and neck sarcoma, you will want an MRI. So head and neck and legs, up and down, you will need an MRI with contrast. Abdominal sarcoma, CT scan is okay with contrast. You have to again do a CT scan of the chest or an X-ray of the chest to see if the disease has spread to the lung. That will complete your staging process. So, as we always discuss on Cancer Reach, I will do tests to confirm my diagnosis. What is that test? That's a biopsy. That's a needle test. So, I'm going to do a test to confirm my diagnosis, which is by a biopsy, which is a true cut biopsy, which is a needle test. And my second test will be test to confirm the stage of the disease or the location of the disease. That will be an MRI of the extremity and a CT of the thorax. Then finally, I will do tests to know the general health of a patient, which is your complete blood picture, renal function, liver function test, heart, 2D echo, pulmonary function tests, etc. Finally, in certain sarcomas, you'll do something called a translocation studies. That is, in certain sarcomas, certain molecular signatures, what do you say, are pathognomic of that sarcoma. So I'm being very technical here. So to put it very simple, you will do on the tumor tissue certain molecular test. If somebody has that molecular test positive, we say that's called a translocation. That means you have that sarcoma. For example, X18, X chromosome 18 means you have synovial sarcoma. For Ewing sarcoma, you have a translocation. We do fish for Ewing's, we call that test. So for Ewing sarcoma, you have a particular translocation. X18 is seen in synovial sarcoma. So biopsy to confirm my diagnosis, local staging with MRI, systemic staging with CT or X-ray, and finally, in certain sarcomas, molecular studies.
So, between the early stage of the cancer and the advanced stages, which is more common in your clinical practice?
Uh, Most of them come in early stages at presentation, but they can probably develop mets at a later date. So early stage is or a resectable stage is the one which we generally see.
So, once the patient has been diagnosed, what are the treatment options that are presented to the patient?
See, as usual, surgery, radiation, and chemotherapy. So let us be very simple. If the disease has not spread, if it is operable and resectable means it can be removed by the surgeon, that patient undergoes surgery. If you cannot remove it forever, in the sense if the surgeon says, I can never operate on this patient because of the bulk of the tumor, the location, you will probably give radiation with or without chemotherapy. Again, if the disease has spread elsewhere, you will probably give only chemotherapy to prolong the life of a patient and quality of life. That is called palliative. Sometimes you may give radiation to shrink the tumor and make it amenable for surgery. Or sometimes after surgery, the patient may get radiation or chemotherapy. So, to put things into perspective, if your disease has spread to stage 4, you usually treat them with systemic agents, that is chemo. Not spread, operable, you will operate. After operation, some patients may require chemo, some patients may require radiation. That is depending on the age, grade of the tumor, depth of the tumor, etc. Sometimes, if you cannot operate upfront, uh, experts may feel that radiation may probably shrink the tumor and take you out for surgery.
Sir, if a patient has undergone surgery, would it be necessary that there would be amputation done and the patient can have future handicapness in any of the cases?
So, see, uh, if you have, so it depends on the size of the tumor, the location of the tumor. The surgeon would at most times not want to amputate a limb. But if removal of the tumor completely requires that your limb has to be amputated, you have to do it. You cannot leave tumor behind. We need to have negative margins, we say. That is when we remove the tumor, we should not have tumorous tissue left behind. So the patients would require amputation in that cases based on the location of a tumor.
How does the prognosis differ for patients with early stage of the disease and for those with advanced stage?
See, early stage is curable, advanced stage is incurable. Early stage patients get a curative surgery done. Advanced stage patient surgery generally is not advised. We give them chemotherapy to prolong their life. So obviously the results are dismal in advanced stages. But in early stages, obviously, there's a very high chance of recovery and cure.
Sir, are there any recent advances regarding the treatment of these tumors?
There have been a lot of chemotherapeutic agents which have been not recent, but yes, over the last few years. For example, some of the drugs like eribulin, trabectedin, or we do NGS or next generation sequencing in these tumors. And if they have certain particular type of mutations, they are eligible for certain medications like tyrosine kinase inhibitors or NTRK inhibitors, etc. So these are all some of the advancements in the techniques of radiation, which minimizes toxicity, advancements in surgery, obviously. So there have been a lot of advancements which has helped patients who are suffering with sarcoma.
Sir, how do you advise your patients to live their life once they have been diagnosed with this tumor?
See, madam, it all depends. See, again, depends on the age of the patient. With a young patient who has a limb sarcoma, whom you probably have to amputate, as we spoke last time, there needs to be a lot of motivation to that individual. See, and you have to tell him him or her that, yeah, this is for a curable cancer, but you may live with morbidity. But now, yes, you have so many good shoes, prosthesis, and all that, that you will not have. It is not very clearly, what do you say, visible to somebody that you have an artificial foot. Yeah, maybe functionally, obviously, it is not like a normal foot, but definitely it serves your day-to-day purposes. And what we have to motivate our patients is the bottom line is we have to get it removed so that we are cured completely. Those who have metastatic disease, our emphasis should be on quality of life rather than quantity of life. That they should live well without pain, without suffering. those kind of the things. So these things require, and more importantly, they have to be motivated to stay under follow-up because there could be a recurrence. And last not the least, there are some medications which we give, for example, adriamycin, which can cause heart failure in the long term. There can be second cancers which these patients can develop. So these patients should be on a regular follow-up. And few years later, we should be aware that they can uh, suffer due to heart failure because of their prior chemotherapy, or they can also have second malignancies which are chemotherapy related. So they need to be under close follow-up, not only to look for recurrence, but also for these other treatment-related long-term toxicities.
So, what would be your advice for lifestyle changes for these patients?
Healthy food, uh, exercise, whatever is possible. See, once the limb is cut and all that, then there's a tendency to put on a lot of weight because you become sedentary. Try to avoid that, not in the immediate post-op period, but later. Of somebody who's had a retroperitoneal sarcoma and a large surgery, then take small frequent foods, high fiber, fruits and fruit juices, so that they're not constipated and all that. Good amount of protein to build up the muscle mass. And that's about it. Nothing specific, actually.
But at what intervals of time are these patients expected to come for the follow-up visits?
They come first 2 years, we call them every 3 months. If they have a no recurrence after 2 years to the next 3 years, that is up to the age of up to 5 years, we call them every 6 months. Once it is 5 years, technically, though they are cancer free, we would still call them once a year. And during this period, just we'll probably do a X-ray here or a CT scan once in a while to just check if it has spread. Otherwise, a general physical examination is more than enough.
So, what would be your final message to the public for this Sarcoma Awareness Month?
See, uh, sarcoma awareness, what we should understand, it's a very, very rare tumor. Somebody presenting with a limp or a swelling, which is painless, which has been there for some time, just not going away. Uh, Go consult your doctor. It could be something fish. It could be something different. And if it is proved to be a bone or a soft tissue tumor, then you need to get an MRI. You need to get a CT scan of the thorax. You need to get a biopsy to prove it is a sarcoma. What type of sarcoma? And then it's a multidisciplinary effort. The radiation surgeon, med, ortho, oncologist, everybody has to sit and discuss what is best for the patient, whether it is surgery upfront or radiation later, etc., etc. And generally, they are present in an early stage, so cure is possible, and we should aim for cure.
So, can you tell us about the second opinion campaign that you're running?
So, as you all know, on Cancer Reach, we have a second opinion campaign, so patients can reach out to us. We already have had quite a bit of patients who are reaching out to us. This is especially for those patients who do not know what to do once they have a cancer diagnosis. Put in your reports to the WhatsApp number, and we will give you an opinion. Uh, this is purely to guide you. The online opinion is not, uh, what do you say, a replacement to a physical check or a doctor seeing you physically, but this is just to guide you so that you can make informed decisions.
Thank you for educating us on sarcoma in this session, and we hope to again see you with another interesting topic next Friday, sir. Thank you for your time.
Thanks so much. Bye.
Thank you, sir.